This is a 39-year-old female working lady who is premenopausal. She is hypertensive and she doesn't have significant family history of malignancy. She doesn't have any significant past medical history related malignancy. Hence, she had history of 3-time cesarean section. In late 2018, she felt a mass with mild pain in her left breast and pain in the back and went for evaluation. On histopathological evaluation in August 2018, her left breast mass biopsy reveals invasive carcinoma of no specific type, preferably ductal NOS. Her immunohistochemistry report reveals ER positive, PR positive, and HER2 positive. We do PET evaluation for her due to her bone pain in August 2018, which reveals left breast malignancy with axillary level 1 and 2 nodal and extensive axial skeletal metastasis. So her clinical stage was T1, N2, M1. So this is a stage 4 metastatic bone disease. So we started HER2 targeted palliative chemotherapy with docetaxel, trastuzumab, and zoledronic acid till February 2016. Meanwhile, palliative EBRT was also given to her in the right ninth rib in October 2018. She undergone maintenance trastuzumab followed by palliative chemotherapy. She can afford cycle 9 trastuzumab till May 2019. Unfortunately, she could not continue cycle 10 trastuzumab in June 2019 due to financial constraint. Then she underwent evaluation by PET-CT scan, which showed mild progression of the lesion in the breast and axilla with stable skeletal metastasis. So in July, we add tamoxifen 20 milligram once daily, along with the 3-monthly LHRH agonist, and we then do PET evaluation in October 2019, which reveals regression of the metabolic activity of the primary lesion along with the axillary nodes, but there was stable skeletal metastasis. Trastuzumab due to financial constraint, and therefore she was underwent some breast swelling and pain problem. So we advised her to continue the trastuzumab from October 2019. Fortunately, she could continue 18 cycle of trastuzumab till March 2020. In this total treatment, she could not afford 3 months of treatment due to financial problem. On May 2020, she presented with anorexia, nausea, generalized itching of the whole body, eye color change, and high color urine. We investigate bilirubin and SGPT, which reveals 7 bilirubin, and SGPT was 359. MRCP was done, which reveals higher soft tissue mass causing mild biliary obstruction and left-sided mild pleural effusion with no ascites. We again do bilirubin test in June, which reveals raised bilirubin from 7 to 11.3, and HGPT was reduced to 110. She also presented to us with respiratory distress, and initial investigation, there was massive pleural effusion, so she underwent tube thoracostomy on June 13, 2010. Tube was coming out spontaneously after 2 weeks, so pleurodesis was not done then. She also underwent ERCP on June 17, 2020. Repeated aspiration of peritoneal fluid was done due to huge ascites, which was about 4 times daily, and along with albumin support due to hypoalbuminemia. On June 2020, her ultrasonogram report showed huge ascites for which repeated aspiration of peritoneal fluid was done. After that, in July, she was underwent some basic investigation. Here, her bilirubin status was improved from 11 to 1.1. and creatinine was 1.97. So we started Tykerb and Xeloda. Tykerb is lapatinib and Xeloda is capecitabine since the end of July 2020. Before that, she was evaluated by PET-CT scan. The PET-CT scan showed multiple primary lesions in the left breast, along with new appearance of lesion in the left supraclavicular lymph nodes, multiple abdominal lymph nodes, and new lesion in liver. That's why we advise lapatinib and capecitabine from July 2020, and still she is undergoing this protocol. English injection denosumab was suggested due to raised creatinine, but she could not afford due to financial constraint. After that, in September 2020, she was evaluated by ultrasonogram, bone scan, and CT test and liver. Fortunately, ultrasonogram showed no significant findings, no homogeneous hepatic parenchyma, and there was bilateral mild hydronephrosis. In bone scan of January, there was lesion in fifth rib, right rib, left second rib, post aspect of the 10th rib. And on 2nd of January, CT test and liver showed variable findings. Diffuse skeletal metastatic status was stable. The lesion of the previously stated right lower lung was partially resolved, and diffuse parenchymal heterogeneity involving both right and left lower lobe, left lobe of the liver was no progression that site, and also almost static kind of lesion in the primary lesion of left breast. Fortunately, supraclavicular lymph node and left axillary lymph node status was resolved, and loculated pleural effusion is static. So I can tell that there was a huge progression from the previous PET-CT scan after this treatment. Now, 20 days ago, she was presented with new ulceration at the site of the left breast, and the mass on the left breast size feels bigger than before. The ulceration was along with associated with bleeding, and also the back pain increases than before. No further evaluation was done so far since 1st of January 2021. So my question here is that what will be the next course of treatment plan? And in such financial constrained group who cannot afford a higher chemotherapy regimen, how can we proceed in case of this kind of people? How can we explain about hilar mass causing biliary obstruction or ascites? This is my question. Thank you. Thank you.
Thank you very much. Quite a complicated case and a difficult scenario, I would say. I'm requesting Ben Patsal.
Yeah, this is unfortunate. I think the hard part about this is, as you put in that third bullet point, the financial constraints. I think most of us are probably thinking that she would benefit from a course of some sort of taxane with Herceptin and Perjeta or Kadcyla, also known as PDM1, because those really would be the next lines of therapy, at least in this country. And I don't know if those are available to you or whether or not you can somehow get some sort of compassionate use from the drug companies, Genentech. Genentech does have some, medical assistance programs, and they are the ones who own the antibodies. There are biosimilars coming out, and so that might be something also to explore, but I don't know how available they are in the rest of the country. But for me, she clearly has HER2-positive disease that needs to be treated as such. And lapatinib, though it was, or it still is an approved drug, has fallen out of favor in this country for many reasons because of toxicity. There are other oral HER2 medicines. Again, I don't know how available they are. They're quite expensive as well. Neurotinib, and more recently tucatinib, which seems to also have some efficacy for brain metastasis from HER2-positive disease. So I think that these are all very known and can be quite effective therapies, systemic therapies for HER2 positive disease, but I don't know about availability, and equally important whether the financial toxicity prevents her or precludes her from obtaining those. I think in the absence of that, one could, I don't think she's had an anthracycline yet, so adriamycin, Cytoxan, or just getting doxorubicin. You know, there is older literature that suggests that oftentimes you can get co-amplification of TOP2A with HER2 since they're next to each other on the chromosome 17. And so there were some older studies, particularly BCRG-006, that seem to suggest that if you have co-amplification, the benefit of adding HER2-directed therapies is not as great, if at all, in the short term. So that might be something to try. Again, I don't also know whether BRCA testing is available for you all there, because I think she's a young woman, and even though she's HER2 positive, science and the biology would dictate if you can get PARP inhibitors, again, very expensive, that she might benefit. But at the same time, as I was saying from the previous case, platinum therapies, chemotherapies may also be efficacious for BRCA carriers, albeit with much more toxicity. But that may be something to try, especially if she is BRCA1 or BRCA2 positive in the germline. And obviously it could have implications for her family members and children if she has any. Finally, about the hilar mass, again, that could be a MET, whether, I don't know if you can biopsy that or not. If that is a new primary cholangiocarcinoma, again, it's rare, but you can get GI tumors with BRCA2. And certainly being triple positive, this would likely be more BRCA2 than BRCA1. So I actually think getting germline testing, and if you can get a biopsy of that hilar mass, may help clarify why this young woman is getting either widely metastatic disease or whether or not this could be a second primary. Again, whether BRCA2 could also cause pancreatic cancers as an incidence, and whether or not this could be an extension of a pancreatic mass is also something that's possible that we've seen in the past. That also goes back to knowing what you're dealing with and trying to get a biopsy and trying to get some sort of genetics may lead you down a path of trying to get a PARP inhibitor versus trying to just use platinum therapies.
Thank you, sir. Rajesh Balakrishnan, sir.
Armanshi, thank you for me. This patient has a very disseminated disease to start with. It's like a metastatic breast cancer with a disseminated bone metastasis to start with. And even though the patient was HER2 positive, she had taken Herceptin treatment in a bit, not in a proper sequence. I think there has been a lot of gaps in between. But as of whatever treatment you have done is in a good schedule, what you have followed, tamoxifen you have given, and she was positive and she had good response to it. And when the patient became disseminated metastasis in March 2020, so that's the time I think when she developed visceral metastasis, her course became very bad and she is not responding to any further treatment. And the picture is a bit different from the routine triple negative breast cancer, what we see. We don't usually see such a disseminated lymph nodal involvement, like multiple intra-abdominal nodes, hilar mass, and supraclavicular node, and a lot of nodal disease in the abdomen. Not sure whether any of these nodes were biopsied at some point of time, whether it could be a intra-abdominal malignancy which was coexistent along with this. That's not a thing which has come out. But responses, if you see, when she has responded to lapatinib and Xeloda, she had good sustained response with maybe for at least for 5 to 6 months. Maybe from July to January, she had a good response. That could be because that proves that indirectly that this is a breast thing which has spread to the abdomen. That is one thing. And currently at the end, what you are told is she's having a back pain which is more than before, which is difficult to explain. Only one thing where I could think was like because of PET CT done recently showed, not PET CT, the bone scan and the CT thorax which was done, which showed there was decrease in the bone metastasis, and even the lung and the liver was stable in disease. One reason what the back pain could be was whether it is like a celiac plexus involvement because of the nodal disease which is compressing. That could be one reason for the back pain which I could think of. And another thing, the problem what she is currently facing is the left breast is becoming bigger. There is ulceration and bleeding. Maybe one option currently is to consider palliative RT to the breast. maybe which will keep pain and bleeding in the breast to control to a certain extent. So that is one thing which I could say. That would be the local treatment which I could suggest. And another thing is if she has financial difficulties, maybe capecitabine alone to continue on a daily schedule. Only capecitabine, single agent capecitabine to try. Or if the family is not keen, maybe best supportive care after RT and just best supportive care.
Okay, thank you, sir. So now we move on to Professor Qamruzzaman, sir. Are you there, sir?
Yes. This is a advanced case. Actually, she got a lot of therapies and she had a lot of financial constraint. Even she cannot afford the capecitabine or also Tyca, what we call the lapatinibs. And what I think that what Rajesh has told, as there is a ulceration and bleeding from the breast lesions, she can have a local RTs for the left lesion. And we can think about the pain management regarding the back pain she's feeling from the back pain. I think she should go for the supportive treatments. I think that's all.
Actually, she is a very unfortunate from the very beginning. And during the diagnosis, initial stage, she present with stage 4 disease. So initially, she developed skeletal metastasis. Later on, she developed lung and abdominal metastasis. So, as because of jaundice with obstructive feature, ERCP and standing jaundice come down to nearer to normal. But I am agreed with Professor Balakrishnan. Right now, what has happened, there is a lesion with bleeding or ulceration. In that case, local radiation is one of the options. Other than this, only palliative therapy is needed right at this moment. Thank you.
Definitely, this is a very complicated case and unfortunate lady. And we cannot offer the good treatment for this patient due to financial constraint. And due to financial constraint, the patient did not receive the proper treatment in proper time. For this reason, now she is on metastatic developmental disease. In these stages, only there is, I should say, there is the option for palliation as the patient has a financial constraint. So I am agree with the previous that local radiotherapy may give some benefit for this ulcerative. And also we may put the patient in a palliative medicine. So this is my comment.
Thank you, Salim Reza sir. We had a lovely discussion. Anybody to ask any question related to this case?
Thank you, Ronald sir. I'm Dr. Arifur Rahman Shajal. I would like to thank Dr. Iffat Zaman for presenting this case very nicely. This is really
I'm Prof. Mufaddal. Can I ask a question?
Sure, sir.
It's not a question, rather a comment.
Sure, sir. Please, sir. I'll be happy.
In the initial management of this patient, after failure of the chemotherapy, she was given LHRH analog along with tamoxifen. Though her ERPR score was not very high, it was weakly positive. I would have rather given her, along with Zoladex, aromatase inhibitor, not tamoxifen. Because you are giving aromatase LHRH analog along with tamoxifen, but I would have preferred this. This is one comment. Because definitely aromatase inhibitors are better than tamoxifen once you have suppressed the ovary with Zoladex. The other comment is this lady was frequently tested by PET scan, which is very costly in Bangladesh. On the one hand, we are frequently telling that she could not afford the treatment like trastuzumab. On the other hand, frequently she is being treated, she is being investigated with PET scan. And instead of PET scan, I think a bone scan, a CT scan, chest and abdomen could give these similar informations.
Sir, the explanation is that actually until June 2020, she was treated outside nearer country. And regarding the tamoxifen, my explanation is, sir, she had a severe skeletal mets. So they are, I think they choose for the aromatase inhibitor rather than tamoxifen rather than aromatase inhibitor. And since when we just received the case from the obstructive jaundice, and that's the cause we did later on a PET scan to understand what was her that present disease condition, and follow-up scan we did bone scan and CT scan. So far she's doing good, sir. And thank you all for sharing their views in this case.
Thank you all. Thank you everyone for your active participation in the board. Bye-bye and see you all next month.
Thank you.